Thank you for that truly beautiful introduction. I must admit, the idea that my career has been predicated on the spirit of unconditional love brought the tears welling behind my eyes. I actually need to ask, are you all sure that you're in the right room? I've been lucky enough to do 2 of these presentations at this conference, and actually some of you have even come back. So, and it's great. The whole thing is bursting at the seams. I saw the competition, the brain disease and psychosensory motor psychotherapy and all that. I thought there's not going to be anybody here. Anyway, you are here, and it's terrific. So we're going to do a session. I'm going to speak for a bit, and then Katherine's going to speak for a bit, and then you're going to speak for a bit. And we're going to make sure there's plenty of time to discuss things and to get questions out. We've got a number of questions for you to consider. Now, I'm going to compare some things that went on in addiction treatment 30 years ago with the situation today. And I want to make it absolutely clear that I don't think that there was, I talk about a golden age, and it was a golden age in the sense that things were going on, and that there was an enormous energy in the addiction treatment field in the 1980s. What I'm not meaning to imply is that it was all fantastic and we should all go back to there. What I'm going to suggest is that there were some things that were happening then that are more difficult to get to happen nowadays. And there's some things that have been lost and things that have been gained. And really I'd like to, and of course I can't in the 15, 20 minutes or so that I'm going to be presenting for, cover all of the things that we've lost and all of the things we've gained. I mean, Christoph mentioned huge numbers of things that are changing that I'm not going to address at all because there's not time. But some of the things we're going to talk about hopefully will be relevant. Now, I'm very interested in complete systems, and actually I'm just as interested in individual therapists as I am in treatment agency teams. I'm interested in all kinds of delivery. I'm interested in family therapy, all of those things. Most of what I'm going to say is relevant to, well, hopefully to everyone, but it's going to come from looking at the classic Minnesota Model Treatment Centre that came over to Britain in the 70s and sort of burst into flower in the 80s. And I'm having a look what went on there and what made it so powerful. And the question for you when we've both spoken is, because Katherine's going to address some of the new pressures, some of the new demands, some of the new things we've got to do now that we didn't used to have to do. And the question for you afterwards, when we get the discussion going, is how can we keep the best of the good, perhaps restore things that we've lost, and how can we also move forward and meet the challenges of the new environment, which is a very stringent environment financially. There's less and less money for addiction treatment. And, I believe in the right of people to buy things, so therefore if people want to buy private addiction treatment, it's absolutely their privilege to do that, but it's going to be quite a limited number of people who can access that. So the question is, how do we keep going? When I first went, I sat in a group in a treatment centre as a greenhorn counsellor, very nervous, in 1985, September 1985. And in that group was a High Court judge who was in treatment and a woman who kept all her possessions in a supermarket trolley in the same group. And everything in between in terms of social positioning and privilege. It was fantastic. It was really amazing to me to work in an environment that contained people who were literally living on the street before they came to Cloud, and people who were at the pinnacle of a very well-paid profession, all of whom had been hammered by alcoholism and addiction and had ended up at Clouds. And there were certain things creatively going on at Clouds which made that possible. And for me, that social mix was key to my, why I wanted to work there. I didn't want to work in a silo of people who were, basically social write-offs and being given cheap, minimal, undignified treatment. And I didn't want to work with a place of people where, where everybody was privileged and affluent, had loads of recovery capital. I wanted that mix. So, God, blimey, that's right. It was a real heyday. What was the addiction field like 30 years ago? there was an enormous rise, both in America and in Britain. I could analyse what was going on in European countries as well, but I'm going to stick to Britain, and it's a really odd room to do a presentation in. It also bothers me why they're called suites. They're rooms, aren't they? In what sense is this a suite? There was the government changes in alcohol beds. You see all of the rise in the not-for-profit, the charitable sector, and there's an enormous rise in that from 1978 to 1984, and the total is going up. It's kind of almost doubling in 6 years. The mid-80s were where it was all happening in terms of the offering of residential treatment beds in the States. In America, in Britain, I should say, there was only one private not-for-profit alcohol and drug treatment centre in 1974. That was Broadway Lodge, which opened in 1974. By 1984, there were 25 of them, both for-profit and charitable, and 400 private alcoholism or addiction beds in psychiatric hospitals, a number far exceeding NHS provision. So there was much more going on in the private psychiatric field and in the opening of these treatment centres, and they were all over the place. Britain was crawling with treatment centres at this period. And there were a number of reasons, political, economic and social, for this increase in both countries, and I'm not really going to go into that, except that it was the culmination of something that had been growing since the Second World War and kind of burst into bloom at this time. Cloud's House, a country house in the middle of Wiltshire, which is where I arrived from London, a bit like sort of going down to work in a prep school or something, and I lived in the attic for a bit until I managed to find somewhere to live in Bath. And it was humming with people. There was 40 plus patients at least. They were called patients in those days because, again, that name signified dignity, and I quite like it. It means a suffering person. If I go to the doctor, I don't expect to be a client. I'm a patient. Now, people have different views on this and feel differently about it, but they were called patients because it was a medical frame apart from anything else. There were about 80% alcohol, 20% other drugs, and I've actually named the counsellors just in case anybody is old enough to remember any of them. But there were just such a lot of them. I listed them because I was bringing them to mind as I made this slide. And there were, kind of 11 to 13 counsellors, because 2 people suddenly pitched up and were employed to boost the team to 13, for up to 55 people. There was a full-time medical director and a full-time second doctor at Clouds. There was a clinical psychologist working, I think, 5 days a week. There was a full-time spiritual counsellor. There was a series of Roman Catholic priests because the McCanns were Roman Catholics and they knew these priests, and in they came to do the spiritual counselling, one after the other. One of them was fantastic. I mean, I arrived in this prep school kind of thing, living upstairs in the attic, and I got a knock on the door, and it was Father Matty, who was the spiritual counsellor, and he had white socks on, as well as his normal clerical garb. And he sat down on the bed and he said, "Can I talk to you?" And I said, "Sure." He said, "I've got boyfriend trouble." And that was, it was fantastic. It was just a really nice introduction to the ambience in at Clouds at the time. I mean, honestly, he wasn't talking about the boyfriend trouble to anyone else, but he needed to talk to somebody about it. There was also a series of visiting spiritual assessors. So when people were assessed, and I'm going to talk about this in a minute, there was a space to talk about your beliefs and your values to somebody. There was also a substantial team of nurses. In other words, there was lots of people to do the work. It was a genuine multidisciplinary team. And there were very creative funding arrangements. There were free beds, there were 2 or 3 free beds, there was people coming in under the DHSS, Department of Health and Social Security, residential, it was actually, I forget what it's called, income support or something, but in those days you could come in for £190 a week if you were in a nursing home. and that was about a third of the cost. So the people who ran it said, you can come in like this and the private patients will pay more and it will subsidise the people who were paying less. So it was creativity, it was inclusivity. The model was the Minnesota model, the model that came out of 3 agencies in Minnesota in the 40s and 50s. And there are, that can be distilled to 3 principles. First of all, if there are people there with alcoholism and addiction, treat them. Give them some treatment. Treat them with dignity. It was always a very importantly dignified treatment environment. It went wrong in the 70s and it got all confrontational, but that was never the idea of the Minnesota model, to bash denial and to tear people down and all this sort of thing that went on. It was about giving them a place where people could be treated with dignity, and it was holistic. The idea that addiction was a holistic problem which needed addressing at all of these levels, and physical, mental and spiritual. And it was multidisciplinary. The idea of Dan Anderson and Nelson Bradley at Wilmer State Hospital in Minnesota was, as doctors, we can only address part of this problem. We need other people to come in and help with the other bits. And they started getting AA members to come in and become advisors and counsellors and mentors and things like that. So the whole thing is the nurses, the spiritual advisors, the counsellors, the doctors, everybody contributed to a multidisciplinary experience that was genuine. It wasn't separated out. You didn't go and see. Everybody met as a team and discussed every patient as a person. There was active linkage, much more so than there is now. I mean, I remember standing by the telephone clouds. It was an enormous thing, not quite a wind-up one, but a big receiver and all of this. And I would stand with a client making the call, getting the client to make the call to the AA member who was going to meet them when they left treatment and all that, and take them to their first meeting. It was very active, very assertive, and it gave the client a lot of responsibility to do this, to make these connections. There were in-house meetings, of course. There were people coming in to do, people actually went through the first 3 steps as a kind of preliminary exploration, and the 5th step involved talking about your inventory with somebody else, and there were people coming in to do that from the recovering community. Now, all of this is going on still, but it isn't going on with this kind of multidisciplinary, holistic nature. Things have got split up. People have got, hunkered down to their own particular thing, whether it's being a therapist or being a nurse or whatever. And we also worked enormously routinely with the families, so the families were expected to come in. Margaret Ann wouldn't take someone in if they didn't agree to have their family involved. There was a lot of work with employers. I remember doing a lot of employers' conferences where we would discuss the return to work and what this treatment was all about and what they could expect, and getting people to agree and collaborate on how to get people back to work at the rate that was appropriate. It wasn't luxurious or exclusive. The point of the Minnesota model was that it was dignified, but it was about responsible, communal, ordinary lives. I just quote one of my favourite songwriters, Warren Zevon here, who wrote a song about going to rehab, and he was saying, well, I've been raking leaves with Liza, presumably Minnelli, and helping me and Liz Taylor clean up the yard, left my home in Music City in the back of the limousine, now I'm doing my own laundry, I'm getting those clothes clean. Well, this is an important part of the model. You might come to the treatment centre in a limousine, but when you get there, the most powerful therapeutic thing, which Betty Ford has talked about, and Liz Taylor talked about, and Liza Minnelli talked about, was I didn't have a maid to change my black satin sheets no more. I had to make my bed, I had to do the washing up, I had to live communally. Yeah, and this is something that, well, it's less commonly happening. People are given a kind of perhaps a pampering experience or whatever, and I have to ask the audience about, well, is this a treatment for addiction? What is addiction about? It's about a grandiose fantasy about life meeting your own expectations and adjusting to, having life adjust to you instead of the other way around. And it's about isolating and not connecting properly and not living communally and not valuing relationships and having those relationships eroded and corrupted by the addiction. So we have to ask the question in a treatment, is to what level is this treatment model combating that? And the original Minnesota model was all about that, without humiliating people, without taking them down, it was actually a genuine valuing and welcoming, but you were expected to do the washing up.
As everybody else.
Yeah, everybody was. And, as I say, it was a genuinely multidisciplinary assessment and treatment planning. So every person who went to clouds would meet people from each of the disciplines who would spend time with them, making an assessment, talking to them. What's the issue? How do you see it? So looking at the addiction history, looking at the social history, looking at the current problems, looking at beliefs and values, looking at the psychological issues, looking at family relationships and how much support there was. This was done not by filling out a form and ticking boxes. It was done by spending an hour and a half with the client and writing that up and sharing that with the team. And as you can see, we had the resources to do that because we had this nice big team and everybody was there. And of course at Hazelden, which was the model which we all were copying at the time, even more people. So there would be an activity specialist who you would meet to do your exercise program and your recreation program. There would be an aftercare specialist who produced your aftercare plan with you. So the whole thing is extremely multidisciplinary, and each of these assessments would be discussed by the team to create the individual multidimensional treatment plan, which was then discussed with and agreed with the client whose plan it was. So there was, and this happened with every single client, come what bloody may. There were no excuses. We spent time on every Friday with everybody who had been admitted in the last week, making this treatment plan, and then making sure that it was there for people quickly and kind of expeditiously so that it could actually be worked on in treatment. It's no good producing a treatment in week 5 of a 6-week program, for example, because it's too late to work on the issues. There was great stress on team working. We really were told these are not your clients as an individual caseload. They belong to the team. The therapist is the team, the client is the group. And this was a real watchword to discourage the development of dependent relationships on a single counsellor. When I began to train people, they would read, there's a significant event journal which each person would write overnight and then they'd leave it in a box to be read in the morning. And the novice counsellors would run to their own caseload. And I said, don't read those ones, read everybody else's. Because it's not just your caseload you need to know the whole group. So each member of the team knew all the clients in their group. And also they were working directly and consistently with family members and offering those family members help in their own right, not just using the family members as leverage to somehow to persuade the addicted person that they'd been this dreadful person who'd done all of these dreadful things. It was more saying, look, as a family member, you are actually suffering stress and distress in your own right, and here are some things that you can do to address that if you'd like to. Now, this was all possible. It sounds really ideal, and it was. It was absolutely fantastic. I mean, training in that environment, working in that environment for 4 or 5 years before I developed the training programs, gave me a real grounding in how things can happen really consistently, really effectively. The use of more than one brain to develop the treatment experience of a client was so useful. But there was hardly any regulatory compliance requirement. We were registered as a nursing home. We had to be that to offer the medical services. But it wasn't difficult to obtain it. There were no published standards. There were no inspections. The funding, well, the statutory funding was income support, 190 quid a week. And occasionally the probation service would pay. ILPS, the Inner London Probation Service, like Clouds House, used to get their clients to come down and would pay for them to be in the treatment. Occasionally GPs would refer. Okay, private, there was plenty of private. People actually did pay out of their own private funds, or health insurance paid for it, or employers quite often paid for it. Well, what happened? The Community Care Act was one of the big huge things that started to dismantle this, and because instead of these creative and individual type of funding arrangements that could be kind of massaged out of local authorities or whoever, is there was suddenly this system which people had to go through. And I mean, something like city roads where you could just pitch up and get admitted literally on the doorstep. You couldn't do that anymore. You had to go through a community care system in order to get a community care assessment from a budget holder who was only had this little amount of money and da 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 da. And we suddenly found ourselves having to be making redundancies. Suddenly this treatment centre from 55 went down to 30, and the counselling team was slashed in half because we couldn't afford it anymore. It's not all down to community care. That's just an example of the kind of changes that occurred. And the insurers and employers took fright at the cost in the 80s. Suddenly they realised. So, for example, the General Motors bill for employees' addiction treatment in the United States in '97 was $78 million. They used to talk about $1 million. You remember the guy in Austin Powers? $1 million was a lot of money in those days. So 78 of them was even General Motors had trouble justifying that. And then they brought in this aggressively managed behavioural health care, managed care. And people don't know this, but half the addiction beds in America disappeared. The industry was absolutely, completely, I don't know what the word is. Decimated isn't good enough. Decimated is only 1 in 10, by the way. So it was ancient Roman punishment where every 10th soldier would be executed. So it was more than decimated. It was decimated 5 times. So 50% gone in a few years, 2 or 3 years. So they reinvent themselves as, kind of Dallas, Arizona experience. Let's treat codependency, etc., etc. I mean, an industry is entrepreneurial, like the kind of mammals in the Jurassic period that were sort of working out how to whistle through the undergrowth and develop how to come and take over from the reptiles and rule the world. Addiction treatment does that as well. Works out strategies. So. Also, the UK insurers took fright and didn't want to pay for it. So they started saying, well, if you take out a new Booper plan, you have to opt into addiction treatment, which of course nobody ever does because you don't know that you think, I'm going to need addiction treatment in 10 years' time. And it's cheaper if you don't tick the box. So people would opt out, and then when they needed it, the insurance didn't cover them. And as I say, when the Community Care Act kicked in, clouds registration went down from 55 to around 35. And there were significant treatment team redundancies. I'm nearly done because I've done this historical canter, and then
that wasn't in the slides, was it?
No. So we've lost a lot. This kind of beautiful, creative, well-funded, fat industry has become very lean. But we've also made huge progress, which I'm going to address rather quickly, and I think Katherine will elaborate on. I mean, we do know a bit more about gender issues nowadays. There's some attempt to address those in treatment, as opposed to this idea that a treatment system that was essentially set up for white middle-class men would just do for everyone. So there has been progress there, sexual orientation issues, cultural needs, some progress. We've gained knowledge around evidence-based interventions, extremely problematic in my view, but we do know that some things work and some things don't work. The vast and mainly positive evidence base of the role of mutual aid. When I came into the field, there was one published research study about AA, and it was negative. It was one where they made some Texas felons go off to AA, and they'd done worse than if you didn't make them do that. That was it. That was the evidence base. Now, there's hundreds of papers. Practically all of them show that mutual aid is a really good thing. If people affiliate to mutual aid, it really enhances outcomes in all kinds of ways across all kinds of different ethnic groups, genders, etc. Expanded recovery communities. The legacy of family addiction. I'm not quite sure what that sentence means. I wrote it, but it must have been late at night. And we do understand more about the trauma. One of the key insights of the Minnesota model was that addiction is a primary thing. In other words, your problems don't cause your addiction causes your problems. Now, this is still a radical and useful way of looking at things, but we also have to realise that for a number of people there are underlying experiences which complicate their addiction and also make recovery more difficult. And we understand that a bit better, and we are prepared to address it more than perhaps we used to do that. So there have been, and I could talk more about those gains. So we've lost things and gained things. And I think this is you. Okay, so I'm going to sit down, and Katherine is going to stand up.
Thanks, Tim, for that history lesson. It's very nice. So Tim's talked to you about the history of addiction treatment and his experience also of becoming a practitioner in the 1980s. Now, fortunately, I'm too young to remember that, so I'm going to talk to you about kind of 2000 plus. Tim's already said to you about the progress that we've made, and gender issues in particular. So we have a unit on our degree programme which is a diversity unit, and the case study that we're using for our students is a transgender case study. So we're kind of even moving beyond male and female, and we're going into transgender as well. But the problem is, with progress comes some additional requirements. And what we can see here is just some example of what progress means. So we've got things like the Care Act, the Mental Health Act, the Equality Act, the Health and Safety at Work Act, the Homelessness Reduction Act, the Mental Capacity Act and the Deprivation of Liberty Safeguards, the National Institute for Health and Care Excellence, UK Drug Strategy and Care Quality Commission. Now, they are just some of the things that we need to be aware of nowadays in addiction treatment, and we have to tick all of their boxes. And there are more on top of this. So it's not just about making sure that we can show that somebody's had a good treatment outcome. We also need to make sure that our treatment, our interventions meet the requirements of all of these different people. And that is just a small list. That's not an exhausting list of what we've got to meet and comply with. Thank you. So when I first started getting in 2003, the creation of supporting people teams and local authorities introduced a significant change to the way that third sector organisations were assessed, and that included substance misuse organisations and services. So the quality assessment framework was created by supporting people by local government. It contained 5 objectives and 21 standards. Every single one of those standards were then graded at levels A, B or C. And the QOF asked for specific evidence to be provided at each level. And I'm just going to show you one very, very tiny section of the QOF so that you can understand, and I'm sure some of you are very familiar with this document, but this is just one section of the QOF at level C, and that's, so you can see here that assessment and support planning is the standard. Then you've got the requirement there for this particular one, and that's at level C. So this would be judged at level C, B, and A. You then get something else that would come under assessment and support planning, which would be judged at C, B, and A. Now, what they did do was quite helpful. They asked us to produce some evidence, and they spelt out that evidence of what they wanted us to provide. So the needs and risk assessment policy and procedure is written down and reviewed in response to changing legislation. So that meant that, not only did we have to have policies, we also had to keep up with all of those regulations and acts. The procedure states how clients will be involved. So you heard Tim talking earlier about, actually back in the 80s, it was a very collaborative process with clients. Well, they didn't necessarily say that that's not how we should be doing things. It's written down in these documents. But as we might start to see, what happened is that those burdens, those legislative and regulatory requirements, started to make that a bit more difficult. How can we collaborate with our clients when we've also got to tick all of these boxes? And it goes on, and it goes on, and it goes on. And I managed to scare our honours students because they have to do a unit on this in their degree as well. And they've got 2,500 words to write an assignment on this particular subject. They can only squeeze in one thing. So out of a document which is 50 pages long, they can probably write 2,500 words on half a page. And that's it. That's how much evidence and information that we need to provide. But moving forward, in 2009, the Care Quality Commission was introduced, and the regulation of substance misuse services came under their remit. So it was previously formed from the Healthcare Commission, the Commission for Social Care Inspection, and the Mental Health Act Commission. And in 2015, the CQC announced a revised approach to their regulation and inspection of substance misuse services. And one of the major changes that has been resulted as a result of that is the reclassification of residential treatment that's got inpatient services such as detox as hospitals. And that's had a significant impact on places like Clouds House, Action on Addiction's own treatment centre in Wiltshire, for example, because the requirements have suddenly shot up. And if you look at the CQC standards, again, we have got something very prescriptive and very, very detailed. It's got 5 standards: is it safe, effective, caring, responsive, and well-led? But we've got 6 key lines of inquiry for safe and 38 prompting questions that we have to answer and provide evidence for. Is it effective has 6 key lines of inquiry and 34 prompting questions that we have to answer. Every single one has to be accounted for in order for us to pass our CQC inspection. So it does seem as though we've made progress since 1985, since Tim became a counsellor at Clouds House. And we've developed a greater understanding of individual difference and needs. We have legislation and practices in place to better protect people from abuse. Expectations are specified in the form of consistent quality assessment frameworks and more regulatory standards. And we've got the regulatory bodies who scrutinise us. But it also feels like we might have lost something along the way. And if we look at the recent CQC criticisms of residential drug and alcohol services, they found that many of the clinics, they weren't assessing risk to the standard that was required and to people prior to their admission. So they were accepting people into services without actually understanding what it was for that individual, what they were dealing with in terms of that individual. Following recognised national clinical guidance on treating people who are withdrawing from alcohol and drugs. So they were finding the medical interventions wanting as well. Storing, dispensing and handling medicines appropriately. Carrying out full employment checks on sufficiently training their staff. Now, I don't know what everybody's training budgets are like in this room, but I certainly know ours have been squeezed and squeezed and squeezed and squeezed. And so how are we able to educate our teams in an ever-decreasing financial circumstances? And nearly 3 in 4 providers failed in at least one of the fundamental standards of care that everyone has the right to expect. So this is recent. This is a recent thing. Almost 2/3 of providers were not meeting the requirement for providing safe care and treatment, which is quite shocking considering we've been doing this quite well for quite a long time, and then all of a sudden this happens. Very recently, that's supposed to say September 2017, not September 2007, the ACMD wrote to Sarah Newton MP, who was responsible for safeguarding and vulnerability on the 6th of September. And they said that they were really concerned about the impact that commissioning cuts and ever-increasing regulatory frameworks were having on the outcomes in treatment. So they highlighted things like the reduction in local funding is the single biggest threat to drug misuse treatment outcomes. So the more and more we are cutting funding, the more and more we are squeezing staff teams, the more it's going to affect how the outcomes for our clients. The quality and effectiveness of drug misuse treatment is being compromised by under-resourcing. There is an increasing disconnection between drug misuse treatment and other health structures. Time and time again, I hear about people with co-occurring mental health problems and addictive disorders not being able to get the right treatment, not being able to access what they need, because it's either the mental health teams are saying, you have an addiction problem, go and have addiction treatment. You get into addiction treatment, and addiction treatment say, but we think you've got an underlying mental health problem. Now, at some point, we've got to work together. At some point, in order for our clients to have the best possible chance of recovery, both in their mental health and their addiction, teams have to work together. Or we need to figure out a way to educate our staff teams so that they are multidisciplinary in themselves. Frequent procurement of drug misuse treatment is costly, disruptive, and mitigates drug treatment recovery outcomes. Now, I started my career in an era of local authority commissioning where we were doing it every 2 years. Every 2 years, the local authority would re-tender all of its drug and alcohol services again. And rather than being on the front line, I'd be sat in an office filling out the quality assessment framework to prove that we were doing what we should be doing, and so we can win that contract over somebody else. And they were doing this frequently. The current commissioning practice is having a negative impact on clinical research into drug misuse treatment across the NHS and third sector providers. If we don't have some consistency in provision, which enables us to gather consistent data, how can we research the effectiveness of the interventions that are currently going on? We can't. So Tim and I have kind of come up with some things that we think might be the problem, but what we want to do in a minute is ask you what you think might be the problem, but also might be the solution as well. So we feel that some of the practices might have slipped away, or they're done less consistently, or corners are seriously cut. Things like multidisciplinary assessment and treatment planning. You saw the list that Tim presented earlier around spiritual assessments, social assessments, psychological assessments, addictive assessments, etc. Do we have that nowadays to such a high level? Multidisciplinary case management and supervision, clinical supervision for staff as a priority. It seems to be reducing. It seems more and more that people are having to go outside of their organisation to get private supervision, paying for it themselves. Organisations, for some reason, aren't providing that level of clinical supervision that is actually needed for their teams. Whether or not that's because they're too busy sat in offices filling out quality assessment frameworks, I don't know. Role modelling by experienced clinicians, trainees actually learning by direct observation and being observed, having feedback, being able to sit down with managers, and that is part of the supervision process as well, but being able to sit down and reflect on their own practice and continuously improve what they're doing. We don't seem to have the space to do that. Assessment drives me up the wall. Assessment tending to be done by structured form filling rather than a collaborative interviewing process. So we have got a form which consists of, say, 8 pages, which is a tick box exercise. How much are you using per week? When did you start using? Not tell me about you. Talk to me about you, why you're here, what got you here. And you can pull all of that information out by having a collaborative meeting with that person and just a conversation with somebody.
Dehumanizing, isn't it?
Yeah, it's dehumanizing. I do not want to be a form that somebody is filling out. I want to know that the person asking me these questions is genuinely interested in what I am saying to them. That is part of forming the therapeutic alliance with your client. And that happens from before they get into treatment. That has got to start. But if these forms are in the way, then what's that telling our clients? What are we saying to our clients when we're ticking boxes rather than having a genuine conversation with them before?
I'm more preoccupied with complying with the rules than helping.
Yeah, exactly. You become a number, you become a statistic. You become somebody that I'm measured on rather than a human, an individual who needs my help. So what we're also seeing possibly is less sharing of client work across the team, so that multidisciplinary and multimodal approach has really suffered. Things like sitting down as an entire team and doing a case management meeting, they don't seem to be happening. They don't seem to be, it's a quick chat in a corridor or a quick email to say, oh, so-and-so was doing this today, thought you might like to know. The case management meetings that Tim and I are big advocates of don't seem to be prioritised as much as they were. And work is too clearly categorised per role. Your medical, your counselling, never the two shall meet. We have less time to think and reflect. Now, I always say to Tim, when he says in our meetings, I remember back in 1985, and I used to have an hour to read The Guardian in between seeing clients. And I'm sort of like staring at him with death eyes going, that's not helpful. But we don't. We do not have time to read The Guardian. More's the pity. We just don't have the space anymore to just stop and think about what we're doing, to think about our practice, to speak to our team and our colleagues, to have that quality supervision that we should be getting within our organisation. And interestingly, what we're finding is that the profession, the lack of regulation in the profession, is meaning we've got very inconsistent roles across services. So whether that's private residential services or local authority funded community services, there's no standard roles. We're seeing so many different job titles doing similar or the same things, having wildly different pay structures, that we can't really make out what the profession is supposed to be aiming towards in terms of its education. So if we look at CQC, who are now regulating a lot of residential services and community-based services, so they focus more, when you read their literature, on the medical and statutory roles. So they talk about qualifications for GPs, psychiatrists, nurses and social workers. There's a very, very fleeting mention about counsellors having the right certification, but they don't actually say what that certification should be. And the only thing that CQC recommend is that staff who are new to the addiction field look to level 2 or 3 diplomas in health and social care, not even counselling, but health and social care. No, I don't think they have much of a clue. But is that part of the problem? The lack of regulation and the lack of clarity around the professional education that we need people working in the field to have nowadays. But I think we need to ask you what you think and what your experience is to try to figure out where we need to be going with this. And certainly it's interesting for Tim and I, because we're at the Centre for Addiction Treatment Studies, we run a degree programme, and we need to know whether or not what we're teaching is the right stuff. Don't answer. Rupert and Sam down here who are students.
Or any of the hundreds of other people that have been through.
So I'm going to put it out there to the audience. Who's brave enough to speak first?
Where's the mic?
Me, I'm going to speak first because I've got the microphone. Can I ask that you use the microphone, then hand it back? My colleague Lisa has another microphone there. So use the microphone and then hand it back, if that's okay?
Of course, yeah.
Otherwise we'll end up with a debate.
Yeah.
With one person.
Yeah.
That'd be me. I like having a microphone. So who would like to kick off? And in the middle there, you might have to help me hand this back.
Thank you for that. That was great. I've been working in the private sector of private treatments for about 2 years, but for about 10 years I worked within statutory in criminal justice, and I've certainly seen the changes in that time. That when I first started out as a project worker running a needle exchange, and how things have changed and how money's gone. And one of the reasons why I left statutory was purely because I saw a lot of our staff being affected mentally by the reduction and the pressures. I mean, I ended up going to work crying.
Yeah.
In a job that I love, people helping, and I was crying going to work. I had a caseload of 110. Most were, problematic, social services involvement, high risk, using on top. So every day I was thinking, who's going to die under my care today? And it was really, really tough. And a lot of that about, the prescribers' services were not working with us. So of course they would go to the prescribing for the prescriptions, but wouldn't see us for the psychosocial. So there was a lot of trying to, and this was in Essex. There's a lot, London services were a lot different, but in Essex it was very much split. But yet social services, a lot of London models base it on the Essex model. So there was a lot of good things in all sorts of boroughs, but it was really tough to watch that money go down. And a lot of that we felt from a worker's point of view at that time. I mean, I'm a manager now in what I do, but I'll never forget what it's like on the front line. I'll never forget that anxiety going to work because of those changes and the effect that it had And if your staff and your team are feeling affected, how are we supposed to then be able to help the client? And I think a lot of that paper exercise, I was certainly one of them people that was all about the paper exercise. Oh, it's another paper exercise. But a lot of it, and the phrase, excuse the phrase, but what came out was about covering your ass, because that's sadly another part of the reality. Oh, you didn't evidence that person, and this, that, and the other, and oh God, that didn't. If it's not noted, it didn't happen, and things like that. So it was a lot of learning and lessons learnt meeting. But what you was talking about in there, what did help us was things, certain managers and certain leaders that inspired me to go into management were people that would say, well, it's not what happens, it's how we manage it. So it was about looking at lessons learnt meetings. So when it did go wrong, well, what did we do right? What could we do better? How could we, these sort of things that would then build confidence and competence to be able to deal with that. Sadly, I left that because it just wasn't hitting my core beliefs anymore, and I wanted that time. I guess I was trying to chase what I missed of the services that started. But I don't know the answer with the stat services. I even read something about Bristol didn't even get a bid at some point, and I just thought, wow, there it is. You continue in that way. And I work in private treatment, and I'm getting a lot of clients that would be in the statutory services because the funding isn't there, and the families are scrimping and scraping to get those clients, get their loved ones into treatment. So I don't really have an answer, but I just wanted to share that to connect, to really say that I've really seen, and I'm a novice really in the terms of that I've been in the field for, but in the 12 years that I've been around, I've seen some great stuff happen there. But for me, the only thing that keeps me enthused is the people that I work with, and the leaders that lead the way. And how in the private treatment, what we do now, we ensure that supervision is all the stuff we talked about is definitely in my centre. Clinical governance meetings, so that support workers and therapists meet together. So medical, and treatment all meet together. Otherwise, what's the point? What is the point? So I was really sad to hear you say that there's a lot of those things not happening, and I just think, well, they're not going to survive very long because something dramatically dangerous will happen. And it's the only way we can move forward. I don't know the answer. I'm just another foot soldier out there trying to do my best and do the best of my ability with it all. But I have seen it change, and it is sad, but I have seen some great work, and I really sort of resonate with what you had to say. So thanks. That's it.
Thanks. Yeah.
Thank you.
I mean, I'm probably not going to respond to everyone, but I'll just quickly respond to that because I think I've got a microphone. It is true that a well-resourced private business can probably do more of this now than the people who are working with the statutory sector. And I think some of the problems that have led to less access to the statutory sector are benefiting the private sector at the moment. Now that's all fine, and good luck, but it doesn't solve the problem, and we have to find a way of redistributing that access so that more people can get this quality. Because if we just simply take the money away and say, well, the private sector will fill the gap, you have this problem that only certain people will be able to afford that intervention. And I'm really pleased to hear. But we see a lot. The reason why we get a good perspective as teachers of people in placement is we discover that we teach something like assessment, and we find out that hardly any of the students are in an agency where this is done properly. Hardly any of them are. So we get this perspective that it's not just action and addiction agencies, it's all over the place. I'm really pleased to hear that in your agency that is not the case, but it's probably only the well-resourced, kind of successful, flourishing businesses that are able to afford this these days. So what I'd really like people to do is think, well, what can we do? We're not going to get them, we can't transform society and get the funding back in the short term. So what are the solutions? What are the rays of hope? How can we make this a better situation?
Thanks very much. I don't work for a residential treatment centre. It's a day treatment service in Hertfordshire, and it's free at point of access. And over the years, I've worked for several different ones, and when the funding, it goes up to be bid for, and I've get 2 bid across to the next one. I've kind of jumped ship a couple of times now. I'm getting a bit old to keep my feet, but I'm 60 now. But the point that I wanted to make is it's just become so corporate just across the field. The service I work for at the moment, called the Living Room in Hertfordshire, it's a small charity. It's like the corner shop. It's not Tesco or Sainsbury's. And no one's commissioning small charities now, and it's great if you can partner together, but it's really, really difficult. Just the climate, I just wanted to highlight just how difficult it is for passionate people to continue to run small-scale services, just to make that point.
Yeah,
Thanks.
that's a good point. Thank you.
Just a comment. I'm sort of in a process of training, and you know, this is an industry which doesn't pay very much, but the cost of training is very high. And we've talked about. I think something I find extremely frustrating is that you know, we've got government bodies and organisations that are churning out regulations, but taking no responsibility for supporting that through information as to how to, you know, do best practice, and what can government do to provide free online training to people, to professionals that want to work in this area, so that we can raise the standard, certainly at a practitioner level, so that you know, it becomes an affordable thing to get involved in. And I'm wondering whether sort of that kind of bottom-up way could assist a little bit with improving quality and consistency in the industry.
Great, thank you.
I have a question, perhaps more specifically for Tim, but I too come from the treatment industry, the old Clouds, Farm Place and Broadway Lodge era, which was essentially driven by a bunch of zealots and a lot of recovering people, you know, with recovery largely in mind. And although you've introduced the burden of the new legislation, which I suppose how cumbersome it is, and perhaps it has benefits, and perhaps obviously there's a downside to introducing all the legislation. But the question that I really want to ask is do you have any comment about the commercialization of the industry that has occurred over the last 10, 15 years? And of course we have a hall just behind us as a testimony to the commercialization of the industry. And perhaps more specifically what I want to ask you is, through the commercialization of the industry in comparison to the good old days of Farm Place and so on, what do you think we've lost through that commercialization, first of all? And second of all, do you think that treatment outcomes are any worse with the current industry, which is perhaps owned and driven largely by merchant bankers rather than recovering addicts?
Well, yeah. I mean, I have to be careful. I mean, there are...
Don't get him started.
I mean, I personally think that the commercialisation, the commodification of things, even higher education, all kinds of things in our society have been to the great detriment of those activities, and that universities essentially have been ruined because they've been turned into businesses that are there to please the clients and you know the corporate nature. Somebody else mentioned the word corporate. I don't think that's a good thing, but I think there are ways in which it can be mitigated. So you know, when something becomes, you know, the Vice Chancellor of Bath's been stepped down because she was earning £500,000 and nobody could work out quite why. You know, but it was all about huge new developments and getting these new business school and pouring people in and da-da-da-da-da. If the treatment industry, because it is an industry, is able to keep the ethics and the mission and the purpose that why they're there primary, and not allow the commercial and commodification aspects to become dominant, and that's bloody hard because you know, economics rules the world, and it's extremely difficult to argue with money. But you know, if it would be conceivably possible to have a private, commercialised but ethical industry that is there primarily. I mean, the evidence about effectiveness is just not there. I can't tell you that you know, Cloud's House in '85 was more effective than, I don't know, any particular program that's run for profit or otherwise today. They all seem to have about the same outcomes in a way, and the reason for that is because treatment doesn't do the magic. I mean, it can start that magic process, but essentially it's what people do afterwards that's important, and that's where recovery happens. And if the treatment is successful in linking people to the resources they need, including other people, then they're likely to do well. There's nothing really in the actual treatment process other than a kind of inspiration, installation of hope, camaraderie, a sort of feeling that this thing can be beaten, meeting other people who are actually wanting to stop like you, meeting people who actually have done it, some of whom may be working at the treatment centre. I mean, those processes are really powerful, but there's nothing in the technology. There's no technology of addiction therapy. Unfortunately, the commodification and the commercialisation tends to try to persuade you that there is. So we see in the stands around here all kinds of different therapies being promoted, as though, and they all come with, they're all delivered by leading experts. I'm interested to know where the following experts are. You know, they're all, you know. So yeah, I mean, I can get cynical about it, but also I don't want to say that I don't think there should be private treatment, or that, you know, the commercialisation of the industry is altogether a bad thing, because it may be the only thing that allows it to survive. So, you know, I have mixed feelings on this. I mean, I'm an unreconstructed lefty. I mean, everybody knows that about me. So I tend to look askance at it, but I realise there can be, you know, there are a variety of views, but clearly it's interesting that two people should voice those concerns. Thank you.
I just wanted to pick up on something you said, because it was about how we move forward from this, and I totally agree with you. It's about the MDT, and for me, I've worked across NHS and private for about 15 years, and it's true, it's the lack of the MDT, and I was connecting with this guy back here saying, you know, you should go into an NHS unit, you feel burnt out as soon as you start the job, but yeah. I think for me, how I've maintained 15 years in the addiction services, I did two things that have been really effective. And number one, that was accepting my burnout limit is about 2 years, whether it's private or NHS, because same shit, different day, isn't it? It's just a different thing. But the other thing I accepted was actually I've got the power to create my own MDT. And something that saved me in my last NHS role, which was setting up a bloodborne virus service, was I set my own MDT up. So I'd go in every morning and I'd send group emails to GPs, to social services, pass this on to the GTT. And I created that for myself, and it really empowered me really to keep on working with addictions. Didn't take away the burnout, but it helped, you know, and it made it a sort of empowering role again. So,
Thank you for that. That's really, yeah. And a lot of personal energy is required. You talked about inspiring managers. And in fact, where things work well, it's always about a person who makes things happen, despite the system. And I think we all have to stand up and be that person, you know.
Kate Halliday, can you hear me? Yeah. Kate Halliday, Federation of Drug and Alcohol Practitioners. I was really interested, slightly depressed, with the long list of regulations and the fact that the CQC kind of have this blanket approach to residential treatment, and that, you know, it's the level 2 or 3 health and social care. And I hope to provide a little glimmer of light, hopefully. The FDAP, together with the lead employers, are looking at trying to develop an apprenticeship for drug and alcohol workers, which would be aimed at around level 4 educational level, which is certainly a lot higher than what the CQC are pitching at, and also by the apprenticeship levy, lots of employers, whether they're big or small, can potentially tap into that. We're in very, very early stages. The proposal hasn't been accepted yet, but that might be an opportunity to actually provide some addiction-specific training across the workforce.
Yeah, let's hope.
I think that's a really exciting opportunity, but I think as a field, we need to be driving what we feel is acceptable in terms of staff roles and qualifications and skills and experience and that kind of thing. Because if we don't drive it, nobody else is going to at the moment. So we haven't got a kind of an addiction-specific CQC. We've got a CQC who are fumbling their way through. And so we have to be saying to them, we have to be brave in saying to them, this is what we think you need to be measuring us against. This is what we think are the right outcomes for people. Because if we don't start speaking up and we don't start saying it, it's going to stay the same. And we're not going to have the regulation, or the, we're not going to have the same kind of expectations put on as statutory services have. So we need to create that environment for ourselves so that we can create a quality framework around what we're doing and be proud of what we're doing. and have some consistency across the field in terms of what we're delivering and who's delivering it.
I just want to say...
Microphone.
Do I need it? I've got a really loud voice.
Very loud.
Also, do somebody else first.
Oh, okay.
Yeah.
Hi. Sorry. There's a couple of things. I just think, following off with the EPTAP thing, anyone could be registered there. There's with your governing body. That keeps you professional. It also keeps you up to date and gives you access to lots of ongoing CPD and stuff. Okay, some of it's online, but it's better than nothing. And it's better than not being regulated. So at least I think being regulated and quality assurance does keep us professionals. We are professionals. I just think you need to be supported and enabled to continue to learn within your role. That might be down to organisations and managers, and I know funding's a thing. I've worked within kind of the charity sector around substance use services. I've also been tupied over and over and over through different services year after year. Got a bit sick of that. Also, it's no good for continuity of care for your patients. But now I work within an integrated team for a homeless charity. I focus with young people, 16 to 25-year-olds. But I got a mixture of psychotherapists, drug workers, dietitians, healthy relationships workers. We all meet very regularly to discuss cases. We do overlap with our work, but also we diversify our sources of income. So even though I'm employed by a homeless provider, my income, I've always had to kind of tender and put up bids for my own service, even though it started off just as me. Now there's kind of two of us, and it will continue to grow. But I kind of focus our client outcomes really on the group that we're working with, and then we will put forward a sensible tender that kind of matches the outcomes that we're working towards, rather than trying to meet outcomes for the sake of meeting them and doing that tick boxing stuff. And keeping it like young person centred, always asking them to kind of help us influence and drive and shape the service so it is a service that they want and need. And when it comes to kind of like assessments, that whole 28-page assessment thing that takes an hour and a half without even asking somebody what they're here for, there's just too many barriers. But if you can get a young person's or your client's voice and opinion in there to shape that, I don't have a form when I do an assessment. Assessment's ongoing, but the first session is my assessment, but it's a conversation.
Yeah.
All the details that I kind of need to write down after that are written down, but the client isn't sat there with a booklet of me thumbing through it like, we've got to get this through before we can actually offer you anything. So removing barriers and just kind of trying to be creative in a market of offering a service that people want. And I do think there's a lot of professionalism coming from a lot of expertise coming from people that are ex-service users, and that, I think, is just invaluable. But there's no reason to say that if you're an ex-service user, you just stay as an ex-service user. You carry on learning, you carry on becoming more professional, and you adapt, and you learn how to work in the environment, and you learn how to support people with substance use issues. And the substances change, but the issues stay the same, and the people kind of stay the same. Society changes, and the money changes. That means we have to kind of change with that, but not forget who our clientele group are.
Thanks for that. Suzanne.
Oh. Yeah, I got a bit lost on what I wanted to say, but I was thinking much more about the bureaucracy. So my experience, I worked in the field for 25 years, managed Hope House for 17, and as soon as there was a heavyweight bureaucracy moving in, which happened recently with the CQC, basically where I go with it is the NHS, because we were not a hospital. We were a second stage unit. We were not a hospital, and that's how they assessed us, sadly. What happened, for me, what I noticed with the bureaucracy was we lost the ability to be with the client. So client care, because people get so paranoid about ticking boxes, the client care goes out of the window. So that is my first point. That was my major concern, and that's what I noticed happening in the field. The other thing is that having managed Hope House for 17 years, there wasn't one therapist that worked in Hope House that didn't sit down and do a proper assessment. So I found that quite difficult to hear. You know, assessments for us were fundamental. So was teamwork, you know, community, teamwork. So we did work in the old thinking of the 12-step program. But look where we ended up. Hope House closed this year. That's where we ended up, with lack of resources, lack of funding, heavy bureaucracy. So when you say, how do we go forward, I think it's a difficult question.
It is a very difficult question.
And I think, you know, with decreased resources and you know, teams that are being sort of whittled down to nothing, how can you provide good quality treatment?
Well, that's the
How
question.
can you?
It's a
And I think
million-dollar
that is the question. And I think if we continue to say yes, 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 we're going to keep ticking boxes, we're going to be stuffed in this field. You know, I really do, and it is so, so sad to see a women's treatment that was going for 30 years closed down because of lack of resources and heavy bureaucracy. So I just really wanted to put that out.
No, I completely agree.
Well, I suppose I'm just going to follow on from what Suzanne was saying. I think we're where we are. We can't change what's happening. Things are the way they are. It's just about what do we do to move forward now. Now, whatever way we look at it, we're stuck with what we've got. I suppose when it was the Commission for Social Care Inspection, it was quite prescriptive of what you had to do. They told you what they expected you to do. When it changed to CQC, they asked you, how are you going to meet this? Yeah. So hence the inconsistency on what everybody's doing. Now, as you were talking, as you were going through that, the one thing that stood out for me was, okay, we've got very limited resources. I don't think it would take much. It's just because it seems as if all the services are competing against each other for this little pot of money. What stops people from pooling resources? It happens in Essex. If I've got the expertise in my service, and I know that there are a number of other services that have little pots of money, if we put our resources together, we can put on a training day. So everybody has that expertise shared amongst each other. But everybody seems to want to work in silos. I've got this little bit, I'm going to keep it to myself because I want to get something. You know, what stops, I mean, look how we've all come here together now, we're all sharing the learning together. What stops everybody from putting their little 2 pence in to make £10, and that £10 goes towards training, and the training day goes in for everybody?
I mean, that was very characteristic of the older days, was that was much less competitive, defensive practice, where you were kind of guarding your little bit of the territory, and people used to offer things to each other. I mean, Hazelden gave it to us. I mean, they didn't charge Clouds or Broadway for their programme. They sent consultants over, and they showed us everything, and when I went to learn their programme to train counsellors, they just said, take a look, take what you want. And that spirit was really, really useful. Also, when I trained as a psychotherapist, I met this guy called Tony Ryle, who was sitting in St Thomas's and Guy's Hospital forming a psychotherapy service. He didn't have any money to do it. So he was going around meeting people and saying, do you want to be a psychotherapist? Come and work for nothing. Well, I will give you free supervision and free training, and you can be an honorary psychotherapist. And he had about 100 people doing that in Guy's and St Thomas's, and that's where cognitive analytic therapy grew and developed. It is that space for creativity, for energy, for cooperation, for asking people to give stuff. I mean, I don't want people to work for nothing, but in this case, it was, you know, there was a benefit for me to go and give my time and get something back. So yeah, I agree. You know, cooperation. The competitiveness is really a problem. The other thing I would just like to ask you to consider, you may not want to talk about this, is the idea of, does our treatment actually address addiction? You know, in the private market, one of the things that strikes me about the way it's advertised is that it wants clients to come in offering them privacy and luxury and bespoke things and all of this in order to attract people in. Now, I don't know whether that's worse than asking people to do the washing up. And I know they do therapeutic duties at the Charterhouse, and I was told that yesterday, but I'm sure they're very light, and I expect they get the bespoke marigolds to do them in.
I'm going to come back in on that.
Possibly with Charter.
There's time. I'm coming back in.
Possibly with Charterhouse printed on them. Anyway, please do come back in. But yeah. But I'm
I think this will enter a debate. There is no, it's quite important. It's quite important. Of course it is. Yeah. I will say this because, as you well know, Tim, I've worked across the board. I've worked with various people. I started as a volunteer. I've worked with the statutory market. I trained at CATS. You know, I've worked in the statutory sector bit like what Taz was saying.
Yeah, exactly.
No,
I mean, you're one of the most energetic and creative people in the field. I mean,
thank you,
yeah.
Tim. Thank you.
Well, of course you are as well.
I will say this though, whatever way we look at it, there is a subsection of society who live in a certain socioeconomic strata that want treatment the way they want it. Now, the alternative is these people are going to sit down and say, well, I'm not coming in there if I can't do this, I can't do that. For me, if you're the type of person that's got a load of money and you're saying to me that this is the style of your lifestyle, this is the lifestyle you're living, okay, I will provide a facility that will meet that standard. However, that doesn't take away from the level of interventions or treatment I'm going to offer you. So, as you well know, 3 of my therapists came through CAAD. Everything we do is evidence-based. I will not look at it and think, oh, because this guy is of a socioeconomic strata, he's not going to do TD. They do. I mean, they don't clean the toilet. They don't do those kind of things. But they load the dishwasher. They set the tables. So whatever way you look at it, it meets the need. Now, it's sad to see a lot of treatment centers shutting down. But the one question I always ask myself is, if I haven't seen my place shutting down, I'm going to ask myself, what is everybody else doing that I'm not doing? Or what am I doing that's leading to me closing down and everybody isn't? What is the learning? Yeah. You know, look out there, look how many treatment centers there are. A lot of them are fancy, they've got, you know, lovely accommodation, lovely facilities. People do get clean. Now, you're right in what you're saying. How do we measure the quality of the improvement of the outcomes? I wouldn't necessarily tell anybody 90% of my clients stay clean because they're international patients. They go away and I don't see them again. However, if you ask me my completion rates, I can tell you what those are. That's the difference. Thank you.
Well, yes. I mean,
they do wash out without marigolds.
Yes. Listen, I mean, that's a debate for another day, and it'd be interesting to do a session on that. You know, about whether or not luxury in the broadest sense of the word is conducive to people staying in. I'm sure it's conducive to people staying in treatment. But whether it produces the outcomes afterwards, I mean, we just don't know the answer. I'm certainly not going to stand up and say it's better or worse. But there is a debate to be had about this. You know, Liz Taylor has, you know, wasn't short of a bob or two. You know, in a sense, she was asked to, you know, live in a different way. And I'm just asking the question: is that a reasonable invitation? Is it something that is, you know, more likely to produce an antidote to addiction? It's just, you know, I think it's just an interesting question. I don't know the answer.
I think we've got a gentleman at the back, Tim, that needs to...
I've changed sex. It's a lady.
Oh, no, lady, sorry.
Not transgender. Okay, my name's Angie. I've worked in the field since 1981. A long time.
Longer than me. Yeah.
Knew many of the people in that top list there. I've seen things change a lot, and I've seen many things not change at all. The program is pretty much been the program that Hazelden Minnesota model has been pretty much stable. The carrying out of it I've seen be impacted by all the things you've listed there. The NHS used to provide amazing treatments. There were Dr. Max Glatt have fabulous treatment centres all over England. Yeah. All of those have been scrapped. You used to be able to go to an NHS inpatient treatment, 6 weeks, 3 months, go to support fellowships, aftercare. The whole thing used to be there, exactly like Clouds and Broadway used to do. Correct. Absolutely fabulous treatment across the board. Probably nobody in here knows that or remembers that. I do. It was fabulous treatment. I used to work in Basingstoke in the community alcohol service. We had a day program, 6 weeks long. People went into recovery. There was family group. There was aftercare. There was a whole program, recommissioned, threw it out of the window, didn't even look at it. So so much was dissembled. And then all this bureaucracy. My thing is, wonderful that FADUP's doing that training because I'm both a nurse and a therapist and a family therapist, and I thank them for giving me my accreditation. But I'm at work now as a data inputter. 40 years, qualification, experience, knowledge, and I'm a data inputter till the end of this month when I'm resigning, because that is what my life's come to, and I do not want to be that anymore. We need to stand up somewhere and say, please, you are killing the patient with this bureaucracy. Somewhere we have to
the teaching and the
get
police
together
and
actually say, stop, please. Because I'm spending 10 hours a day when I'm on shift on a computer, and I don't think that's helping anybody. I'm certainly not forming a relationship with any patient. And that's what I'm here for. So, thank you.
Yeah. I'm aware that we're coming to the last few minutes. There is room for a few more, time for a few more if people have got things to say. There have been some bright, hopeful things said about the way we can move this forward, and there's been some sad recognition of the fact that things have got worse. Would anyone else like to make any comments?
I'll jump in if I may, Tim.
Yeah.
Thank you. Fascinating conversation, way overdue. I mean, I would feel a lot more comfortable if our sort of standards of care came from a overwhelming need to provide clinical excellence rather than the fact that we are sort of fighting for diminished resources. And I agree with you that it should come from us. But I think we haven't really defined what a successful outcome is. At least in the United States, there is a huge raging debate about an abstinence-based model versus medication-assisted treatment, and it's a really big cultural divide, and people taking very strong positions about this, where, to the gentleman's point earlier, we're not asking our patients what they define as a successful outcome, right? There's quality of life, there's quality of relationships with your family, social functioning. There are many, and it's not just the abstinence-based model. And I think we need to move past that.
That's really good.
I'd like to hear your thoughts on that.
Well, I mean, absolutely. I think this is one of the biggest issues that the field is facing, the idea that recovery can be done in more than one way. And it's hard for people who have a tremendous allegiance to the thing that saved their life to kind of expand beyond that and realise that there may well be people who can sustain and develop fantastic lives on the basis of using medications to support their recovery, either short, medium or long term. And that will be important for the future. Whether or not it's going to address whether there's going to be any funding is another matter. I mean, an awful lot of attention is being paid to the improvement of prescribing treatment, opioid substitution treatment in this country, but it's mostly been talk. I've been on plenty of panels to talk about how it could be made better, but actually not much is changing, and the issue is resource and creativity. I mean, the bureaucracy, I think, does stop a lot of people doing interesting and creative things, because you can't. Somebody's got to have a DBS check, or you've got to fill in that form, or you've got to respond to this particular inspection, or all of that stuff is tremendously dispiriting. I think the private treatment centres are going to have a little bit of grief about it too, but they've probably got the resources to respond and to deal with it. I don't know. I mean, we'll catch up at lunchtime or something and talk about that, because that is a huge area as well. But outcomes, nobody's made people account for outcomes, and when they did, managed care were able to come in and said, well, we get the same outcomes from sending to somebody 7 days as you get from 14, 21, 42 or any other length. So we're going to pay for 7 days or a day program. And we do need to know our outcomes better. I mean, even, OB needs to know where his international patients are doing, really. It would be good if we could follow all that up and get a lot more information about exactly what does constitute an outcome for our programs.
Assessment of recovery capital.
Sorry? Well, I mean, that's a step in the right direction, because it is at least looking at more than just have they stopped using.
So my name is Ali, and I'm running 3 rehab centers in Pakistan. So yes, when I started off, it was for the underprivileged class, and I had to go to the people. The government doesn't get involved, pay any money for the treatment, but I had to go to the business communities and arrange funds and help people to get clean. But in the end, the funds got cut down, and I had to do something to keep that underprivileged center running. So what I did is I opened up a clinic for the privileged class, and the money which I'm getting from that, I'm pooling it in this.
Yeah.
So I'm just wanted to know what are your thoughts on it. Is it right, as we are debating, the treatment centers are being commercialized? Yes, it's a commercial treatment center, but yes, it's also producing recovering addicts as well. So what are your thoughts on it? Is it the right thing or what?
It's fascinating. I knew some people from Pakistan 30 years ago who started an agency called Nai Zindagi, and that's also started with getting people who could pay to come in and have treatment, if you like, the privileged class, and then people who couldn't afford could come into treatment in return for some kind of labour. So they would build the new buildings, or they would, you know, and it's turned into quite a long-standing project. I think it's still there. I think it's doing a lot of things. But it, you know, that kind of creativity is difficult in the bureaucratic and regulatory frameworks that we've got. It's hard to do that. So maybe Pakistan has opportunities which we don't have. You know, it's yeah.
It does happen. In fact, just based on what you were just saying there, I can only speak for what we do in my clinic. Every 12 weeks, I mean, you be a testament to this. Every 12 weeks, I have 4 patients writing as to why we should give them free treatment. And the people who do pay quite a lot of money subsidize those people.
Yeah.
So I've got 2 bedrooms which are specifically for those patients. And they come in. As part of our corporate social responsibility, the primary school around the corner uses the swimming pool, free of charge. All our resources, everything that we use is from the local community.
Yeah.
So we're also trying to give back to the local community as much as we can.
Okay, well, that's fantastic.
There's a market for it, that's why we do it.
Yeah.
Thank you.
It's now, I think we
Before we finish, and thank our speakers, I'd just like to thank all of you, because you're all amazing, and there's some great negatives in recovery. I'm one of the positives. You guys, I went to Promise 3.5 years ago. I paid £11,000 for 17 days treatment, and it was pop stars and princesses. And when I went in, I was both of those. That was over Christmas. My wife and my son had Christmas of normality while I was in treatment. And when I came out, the local authority paid for me to be in treatment in the community with RAPT, the Rehabilitation of Addicted Prisoners Trust, and I did 3 months with them, and actually I did 18 months because I stayed on as a peer supporter. And people like you know, got me through that. And now I sort of feel like I'm one of you, but I'm not quite there. But that's okay, because you know I'm getting to the place where I need to be, and it's because of all of you, and because of people, you know, who do tick the boxes. You know, you tick my box, I'm here. So I'm grateful, and I'm grateful to you today. Thanks.
Yeah, and thanks so much for participating and commenting. Really, really useful. And you know.
Can I just say just one thing? Is that what I've heard a lot of today is about having the right leaders in place and the right people who can support their staff to be creative, to negotiate everything that we've just. And it's not impossible, because we can hear that people are doing it. And so if we've got the right leaders in place and the right support for our teams and the creativity that we build in, then I'm pretty sure that we can negotiate all of the requirements that are now on us.
Yes.
And if you want to prevent burnout, send your students to therapy. Sorry,